Good afternoon, everyone. This is Giuliano. I'm the Med Safety and ADE Regional Lead for the New England QIN-QIO, and thank you for joining us for today's webinar entitled The New England Journey Enhancing Medication Safety. Presenting with me today is Madeleine. Madeleine is a PharmD and the Medication Safety Consultant for the New England QIN-QIO. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. The recorded presentation will be available within a few business days after the webinar on our website. The phone lines will be on mute for the duration of the presentation. We'll take questions at the end, and I'll provide you instructions on how to ask questions at that time. Although the lines will be muted, we want you to actively participate in this session. You'll have an opportunity to respond to questions and weigh in via chat. My colleague, Lynn Chase, the Regional Care Transitions Lead, will be monitoring and responding to chat during the session. We'd love to learn more about your efforts and how we might best support you going forward. It's important to note that today's speakers have no conflicts of interest to disclose. So this is the first overview of our almost two-year-long journey to collaborate on strategies to improve medication safety and reduce adverse drug events across different care settings. Our learning objectives for this program are to differentiate between an adverse drug event, a potential adverse drug event, and medication error, to describe why antibiotics, anticoagulants, diabetic agents, and opioids are considered high-risk, high-opportunity medication classes, and to identify tools and resources available to assist you in improving medication safety during care transitions. This webinar is going to provide a high overview of ADEs, how they impact both the patient and the healthcare system. We'll look at the high-risk medication categories that cause the highest rates of ADEs to address how we may be able to influence change by implementing safety tools and techniques to improve patient outcomes and reduce healthcare expenditures. As I shared during this call, we really want you to use the chat feature to get to hear from you, to see what you're doing and how we might be able to provide assistance for you. So let's start by seeing who's on the call. Please type in your name, your organization, your role in your organization, and your state. I thought we would begin today's discussion with a picture that really defines what's happening in our patients' homes across our nation. This picture shows many different medications that an elderly patient has in her home and is expected to manage on her own. Please note, this isn't inclusive of any of the over-the-counter medications or vitamins that she's also taking. So when we talk about medication safety, it's important to really put a face to the issue. We send people home from hospitals expecting that they can handle this. If you look at the statistics, it's not going so well. As a matter of fact, ADEs have now been claimed as the latest disease state. Lack of patient education, inadequate monitoring, and lack of patient follow-up often leaves patients vulnerable to ADEs. Unfortunately, these ADEs often lead to emergency department visits, hospitalizations, and readmissions. It's our job as the healthcare team to work together to keep our patients from experiencing negative outcomes. In order to understand the importance of addressing this issue, we first need to realize and understand the scope of the problem. While ADEs have their biggest impact on the patient, they're also a major driver in healthcare expenditures. They account for a third of all hospital adverse events. They cause approximately 280,000 hospital admissions annually, and those hospital admissions related to ADEs in adults greater than 65 years of age was almost 25%. What I see as being the most significant fact is that about a quarter of all ADEs are preventable. We can really look at this as low-hanging fruit and an area to begin to focus on. In order to address this issue, the Department of Health and Human Services developed a national action plan to improve medication safety and reduce adverse drug events. This program was created for two reasons: to identify common preventable and measurable adverse drug events that may result in significant patient harm, and to align the efforts of federal health agencies to reduce patient harm from these specific ADEs nationally. Within the action plan, 3 drug classes most commonly implicated in ADEs for Medicare beneficiaries were identified. It was not surprising that the 3 classes were anticoagulants, diabetic agents, and opioids. One issue that we identified early on in our journey was the fact that we needed to have enhanced and more consistent definitions of adverse drug events. When we started out with this work, the one challenge we seemed to continue to come across was the definition of an ADE. We found that everyone was defining this event in different ways, and so they were not all reporting on the same measure. I think those of us in the pharmacy world have experienced the same challenges. Consistent documentation is one of the first steps we need to take to combat this issue. Health and Human Services recommends the Institute of Medicine's definition. Adverse drug events are defined as an injury resulting from medical intervention related to a drug. Most recently in pharmacy, the National Coordinating Council for Medication Error Reporting and Prevention, commonly known as NCMER, identified new terminology to help healthcare professionals distinguish among adverse drug events, adverse drug reactions, and medication errors, and to be consistent with definitions across the medication safety community. They, too, embrace the IOM definition of an adverse drug event. This diagram is a great visual to really paint the picture for adverse drug events, adverse drug reactions, and medication errors. So the definition of an ADE is an injury resulting from medical intervention related to a drug. An adverse drug reaction is any response to a drug which is noxious and unintended, which occurs at doses normally used for disease management. So one example of an adverse drug reaction might be when a patient is given an opiate at a normal dose and they break out in a rash. That would be an adverse drug reaction. It would also be considered an ADE because it caused harm to the patient. So all adverse drug reactions are adverse drug events, but not all ADEs are considered adverse drug reactions. A medication error is defined as any preventable event that may cause or lead to inappropriate medication use or patient harm while in control of the healthcare professional, patient, consumer. A medication error can occur at point of prescribing, dispensing, or administration. So let's consider when an error occurs and the wrong dose of an opiate is given. If the patient falls and breaks a leg, that's an adverse drug event. If the patient doesn't experience any issues, then it would be considered a medication error. So if the medication error causes harm, it's an adverse drug event. This is one area in which we can have an impact in this area of overlap, where medication errors cause harm. They are considered potential adverse drug events, and if we do our due diligence and assess the why or how these occur, we can implement interventions to prevent these from occurring. Again, the National Coordinating Council for Medication Error Reporting and Prevention has further defined ADEs, ADRs, and medication errors as preventable and non-preventable adverse drug events. And they've developed an algorithm which is available on our website for review. In this slide, we've taken the typical categories of the NCMER medication errors, and we've outlined those that are considered to be preventable ADEs and non-preventable ADEs. The categories in blue and orange would fall into the potential ADE categories, and the categories in yellow and green would fall into adverse drug events. As you can imagine, capturing actual harm on a large scale has been somewhat difficult to achieve nationally thus far. Many facilities and organizations are capturing potential harms, near misses, or medication errors, which may be helpful for screening and targeting prevention efforts. These potential harms of pADs are more likely to be reported in the system as no patient was harmed, and it provides an opportunity for strategies to be put in place to reduce the risk of this event from happening again. However, surveillance of actual patient injuries or harm should be prioritized whenever possible to consider the national health impact of large-scale or population-based ADE prevention efforts. Adverse drug events can be the result of many shortcomings in the medication process: incomplete medication profile, patient misunderstanding, failing to communicate discontinued prescriptions, lack of education, and even just saving old prescription bottles can all be factors. Warm handoffs involving adequate communication between hospitals, primary care providers, and community pharmacists at discharge is key to this issue. Socioeconomic issues and social determinants of health should also be taken into consideration. If people can't afford their medications or don't understand the instructions we're giving them, we know that this can lead to inappropriate medication use, which can cause adverse drug events. Ensuring patients have some type of support system is critical, and if they don't have that support, understanding how we can help them may make the difference of keeping them out of the hospital. So let's take a little deeper look into the process a patient takes through the healthcare system and where the fragmentation is. Simply put, the patient sees a prescriber, gets a prescription which is processed at the pharmacy, the patient takes the medication home, and then we really have no idea what's happening once they get home. However, it can be a little more complex. We know oftentimes there are multiple prescribers treating the same patient. There also may be multiple pharmacies the patient uses, mail order pharmacies, big box stores that offer $4 specials or free medications. So prescriptions claims data really cannot be trusted as a complete source of medication, as patients sometimes also pay with cash. So the data we have as healthcare professionals is often incomplete. When patients are at home, we have no idea what they are taking and what they have in their home. Patients tend to keep discontinued meds, which leads to confusion and possible abuse by other family members. Although there are electronic health records, there is still a lot lacking in a central repository for comprehensive active medication profiles. Even if all of the patient's health information was in one electronic health record, it wouldn't affect the community pharmacist unless he or she was given access. Silos exist within the pharmacy profession that need to be addressed in order to truly impact improving medication safety. Ideally, there needs to be active communication among all members of the healthcare team across the care continuum. This can be accomplished by using a standardized health information exchange platform where all members of the healthcare team have access to necessary patient information. Then someone can help monitoring what the patient's needs are and what their outcomes are. Transitions of care are a leading cause of ADEs that occur in the healthcare system. During transfers between facilities, there can be many changes to a patient's medication regimen. In our fragmented healthcare system, the need for vigilance during transfers is crucial. We need to remember that this is our patient. Just because they're no longer under our direct care doesn't mean that's where our responsibility ends. When our patient leaves the hospital to head home, what are we doing to ensure communication or warm handoff to the PCP, the home health nurse, or the community pharmacist? What medications have changed? What medications are discontinued? If the patient is going to a skilled nursing facility, who's providing the staff with a reconciled medication list? Is that even occurring? Can the patients afford their prescriptions? Did they pick them up on the way home? There are so many places where systems can fail patients and providers alike. It's understanding where the gaps are and then identifying solutions that can help us to begin the journey to improve the process. So using our chat feature, please take a moment to tell us about some of your medication safety processes that you found effective in reducing adverse drug events and care transitions. We'd love to hear from you. At this time, I'm going to turn the presentation over to my colleague, Madeleine.
Thank you, Margie. Now that we've talked about adverse effects, what they are, how they impact our patients and our healthcare system, let's dive a little deeper into the specific medication classes as mentioned in the HHS National Action Plan for Adverse Drug Event Prevention. Those drug classes include diabetic agents, anticoagulants, and opioids. We will also be discussing antibiotics, antibiotic resistance, and specifically antibiotic stewardship, as it is very pertinent to this topic. Antibiotics are life-saving drugs that revolutionized medicine when first discovered. Today, however, the emergence of antibiotic resistance is threatening our ability to easily treat infections. Antibiotic-resistant infections can lead to increased healthcare costs and, more importantly, to increased morbidity and mortality. The CDC estimates that more than 2 million illnesses and 23,000 deaths are caused annually by antibiotic resistance. These numbers are alarming and have resulted in national and international calls to action. Starting this week, we are engaging outpatient facilities to partner with us to commit to improving antibiotic prescribing by implementing the CDC's core elements for antibiotic stewardship for outpatient facilities. These core elements were just released last week, and they include commitment, action for policy and practice, tracking and reporting, and education and expertise. We know that there has been great success in antibiotic stewardship in the hospital setting, and now by implementing these core elements, we can begin the journey toward appropriate use of antibiotics beyond the institutional setting. Not only will we review the core elements to determine how we can incorporate them into practices, but we will also provide education sessions and webinars, and then share best practices, lessons, and learned. For anyone who is interested in learning more about CDC core elements, we have a link to the CDC core elements webinar that is conveniently after this webinar between 1 to 2. The registration link is here on this slide. Coincidentally, this presentation falls right in the middle of Get Smart Week. Get Smart is a national campaign launched by the CDC to raise awareness to the public about appropriate antibiotic use. This is an excellent platform to discuss what you and your partners are doing to ensure antibiotic stewardship. The CDC's website provides valuable tools and resources that are available for both healthcare professionals and patients to take advantage of to fight antibiotic resistance. So the first high-risk medication class we will be discussing now are diabetic agents. Now, diabetes is one of the most common disease states in the United States. In 2014, the CDC estimated that 9.3% of the population, an estimated 29 million people, had diabetes. It is the 7th leading cause of death. Medications used to treat diabetes may cause low blood sugar, also called hypoglycemia, which is the 3rd leading cause of all adverse effects. These statistics show that the lack of and inappropriate treatment of diabetes can be a major burden to healthcare expenditures and decreases patients' quality of life. Patients not properly controlling their diabetes are at a much higher risk of developing cardiovascular diseases, including heart attack and stroke, retinal degeneration leading to blindness, decreased kidney function, and skin infections that may progress to amputation. Fortunately, there are many medications that are available to help control diabetes. However, 2 of these classes present the highest risk of causing hypoglycemia, and these 2 classes are insulins and sulfonylureas. As a result, patients on diabetic regimens that combine these 2 classes with other agents are at the highest risk of developing hypoglycemia. And this may cause confusion, loss of consciousness, and falls. But while it is important for patients to understand how diabetes may progress and the complications that come with it, if they are not adherent to the medication, diet, and exercise regimen, it is equally, if not so, more important that patients are educated about the risk of hypoglycemia and how to properly treat it.
In my experience, this is Morgan. We have a couple people that are having a hard time hearing you. I don't know if you could maybe speak up a little bit or...
Oh, sure, absolutely.
Thank you.
No problem. Now we will be transitioning over to our next high-risk medication class, the anticoagulants. CMS reports that anticoagulants are by far the most common cause of adverse effects in all parts of the healthcare system. In inpatient settings, 10% of adverse effects are due to anticoagulants, and in the outpatient setting, warfarin alone is to blame for 17% of emergency room visits and 33% of adverse effect hospitalizations. Once again, proper monitoring and patient education are both extremely important for these patients and must be completed throughout all transitions of care. This includes proper INR monitoring. When patients are admitted to a hospital or skilled nursing facility, this is done for them where we routinely check their INR. However, we have to remember when patients transition to the outpatient setting, do they have the necessary resources to get their INR monitored? Do they have proper follow-up by their PCP or their cardiologist? These are some things that we need to take in mind. Warfarin or Coumadin is the oldest and most common anticoagulant medication prescribed. Its long-time use, no side effects, and availability of a reversible agent make it a more comfortable choice among prescribers for certain cardiac conditions listed in these slides. Each year it is estimated about 15 to 20% of those taking warfarin may experience bleeds, while 1 to 3% of these bleeds are life-threatening. So the emergence and use of these direct oral anticoagulants listed above may have decreased routine monitoring, weekly blood draws, and limited strict dietary regimens and modifications, but it is still important to note that the same risk of bleeding will still exist with these agents. Therefore, patients must be educated about this potential adverse effect, again, in every transition of care setting. Lastly, our last high-risk medication class are the opioids. Acute and chronic pain are being reported at an all-time high. 100 million Americans report having chronic pain, and that is more than diabetes, heart disease, and cancer combined. In 1999-2010, the number of prescription opioids dispensed has almost doubled. Therefore, pain is thought to have cost the economy between $560 to $640 billion in 2010. And in 2010 alone, the United States spent $8.4 billion on opioids. Opioids are prescribed to treat pain. However, complete elimination of pain is often unrealistic. Therefore, the goal when using this class of medication is to manage the patient's pain, minimize the burden to daily activities, and increase quality of life. Opioids are not necessarily treating the root cause of pain, so it should be remembered that we are trying to reduce the burden so that patients can go about with their daily activities. Patient education becomes key in this issue as we need to give our patients realistic expectations for their treatment. Chronic pain is often a particularly difficult problem to treat in an area where opioids are often being overutilized. As patients develop tolerance to opioids and require higher doses, adverse effects become more probable. These types of medications should only be utilized for the shortest duration and the smallest quantity as possible. One of the most dangerous adverse effects of opioid medications is respiratory depression. This is the cause of thousands of overdose deaths seen in our country today. Oversedation is also troubling, especially in the older population, leading to an increased risk of falls. Lastly, constipation is another major and common adverse effect that occurs with opioid use. Since this is considered an expected side effect, steps should be taken not only to counsel the patient, but also to provide them with a bowel regimen, both in the inpatient setting and most importantly upon discharge to home, especially if they will be continuing this opioid medication. The biggest piece of education the patient needs to receive is concerning the risk of dependence. Patients should know why they are taking these medications and if they are taking them on an as-needed basis, why it's important to take them only as needed, and what the risk is in taking these medications at all. Finally, we should be providing them with useful alternatives such as non-pharmacologic therapies and non-opioid therapies. Now I will turn the presentation back to Margie to share with you what we have learned along the way.
Thank you, Madeleine. So the primary goal of our work is to improve medication safety and reduce and prevent adverse drug events. We're also focused on reducing hospital utilization for patients who are on one of the high-risk med categories. So how can we, in collaboration with you, impact readmissions or general hospitalization such as emergency department visits, observation stays, and admissions? And as stated earlier, we're spreading the word about antibiotic stewardship in the community and what together we can do to address resistance through education or public awareness campaigns. In order to achieve our goals, we have to screen for adverse drug events and potential ADEs. In order to screen patients, we need to develop partnerships and collaborations in the community. As we work together to better understand the prevalence of ADEs, we'll identify areas of improvement through data analysis and then work to implement evidence-based and proven best practices. So we've been on this journey close to 2 years, identifying and partnering with health systems and healthcare professionals. And we've learned a lot along the way. So I want to take some time now to share with you some of the lessons we've learned to help give you a global view, at least for the New England region, with regards to adverse drug events and pADE data collection. In talking with providers, we've learned that there are many medication safety-related initiatives already underway, but unfortunately, within those initiatives, there's a limited focus on tracking and monitoring adverse drug event data, both from a provider and a system level. We found that there was a lack of communication between pharmacists within care settings as well as across the different care settings. And while the want was there for many pharmacists to become involved, there was not always the capacity built in for them to do the work. In addition, within most settings, we found that the pharmacy department was not always represented at the quality meetings, nor were they aware of the capabilities of the quality department to help support their work. A reoccurring theme we heard across all care settings was that medication reconciliation was inconsistent. Sometimes it wasn't even being done at all, or if it was occurring, it wasn't being done well. It lacked standardization. Given the multiple initiatives underway and the limited data already being captured, we really had to work to align our efforts to help improve efficiencies in the work that's already being done and reduce duplication by identifying synergistic opportunities between projects. We identified areas where we could assist by providing analytic support, tools, and processes to keep our efforts moving forward to improve medication safety across the care settings. So based on the feedback that we heard from you, our partners, our goal is really to support your efforts and to build up existing projects and develop tools and resources to help you track and measure processes and outcomes. So I want to give you a quick overview of some of the projects that we're currently engaged in. The University of Rhode Island School of Pharmacy gives pharmacy students an opportunity to go into patients' homes to review medications and be part of that care transition team. The students are using tools to track the ADEs and pADEs that they identify as they provide education about the medications not only to the patients but also to the care team. Any medication medication discrepancies that the students identify are shared back to their pharmacist preceptor, and then they're passed on to the appropriate team member. So it's really a great project that's been going on for a while, very exciting for our students. We're also working with hospitals that either have or are starting a medication at discharge program. Sometimes those are referred to as meds to go. We've worked with our partners to develop some easy tools so they can measure and track their successes. These tools currently are being piloted in a few of our New England states for review and feedback. In northern New England, we're working with ambulatory care pharmacists that are employed by hospitals but work with specific physician practices to manage patients with complex medication regimens. Special focus is on patients as they transition throughout the care system. So we're working with these partners to help develop measures and tools to track so they can really show the value of performing comprehensive medication management services. Again, based on your feedback, we've developed tools and resources for you. For example, this webinar and our future Med Safety Lunch and Learn series were developed to educate, share, and spread the challenges and successes highlighting our partners. As mentioned earlier, the lack of or inconsistent manner that care settings were handling med reconciliation was also identified as a key concern. The QIN-QIO has worked with pharmacy experts to develop 3 online medication reconciliation learning modules that offer a way to standardize the med reconciliation process. These modules should be available for our partners to access by the end of the year. Involving community pharmacists in the medication safety process is another extremely important opportunity. And we're piloting some high-risk med monitoring tools for community pharmacists to implement in their pharmacies. And basically, this would be to help monitor patients that are newly placed on one of our high-risk med categories. The feedback on integrating these tools into workflow will be critical, as well as measures tracking patient acceptance and program successes. Our QIN-QIO's website has many tools and resources to support you in your med safety initiative. So please make sure to visit the website and let us know what additional information you'd like to see. So as you can see, there's a lot going on. I really only touched on a few of our projects, and we're really thrilled to be involved in supporting these programs. The key really is to track and measure so you can validate the good work you're doing, and then you can use this validation to identify pathways to sustainability. So now that you've heard from us, we'd love to hear from you. Chat in and tell us about your success stories in addressing the high-risk meds or antibiotic stewardship in your care setting. What worked and how can we help you? I think we all recognize the importance of medication safety and how much information we gain if we monitor for pADEs and ADEs. In order for us as clinicians to truly embrace and impact medication safety, it's going to take a cultural change, and I believe needs to start with our new practitioners. Clinicians should be trained in the importance of monitoring ADEs and pADEs. Education should start early, and we should create the awareness of the global impact of ADEs on healthcare system costs and on our patients. We need to focus not only on our own facility, but also to ensure that wherever our patient is going, there is updated, accurate information being shared with the next provider. We need to educate families and caregivers about the nuances of medication and encourage them to be their own advocates and to ask questions. It's so important to engage and empower our patients in understanding and managing their medications. In order to complete the puzzle of how to overcome and prevent adverse drug events, we have to gather as a team, as a community, and build the puzzle together, inserting our respective pieces and recognizing we're dependent on each other to provide the best care for our patients. No matter where you practice, we encourage you to engage with the QIN-QIO. Our goal is to help you to be successful and then share and spread what works. Together, we can solve the problem. So I think we're ready for some questions. You can either submit questions via chat or, even better, open your phone lines to share. Morgan, can you let the participants know how to open their phone lines? And while we wait, Lynn, do you have questions or comments in chat?
Sure. So if you want to ask a question via the phone, all you have to do is press #6 on your phone to unmute your line, and just make sure you haven't also manually muted your phone as well. Again, that is #6. And Lynn, did we have any questions in chat to review?
Great. Thanks, Morgan. Not questions per se, but we're hearing lots of sharing, and I just wanted to highlight a few of the things that we've heard about. In Bay State, it sounds like they have a Meds to Go program, and I don't know. I see a few different individuals from Bay State. If you wouldn't mind telling us a little bit more about that particular program, what's involved.
Again, it's #6 if you want to unmute your line.
Great. Thanks, Morgan. And as we wait for excellent.
So I actually just hopped onto your webinar, but we do have a prescriptions to go service here at Bay State. Were there any specific questions that you guys had regarding that?
Yeah, we'd love to hear more about it. And Margie, you were gonna go in for a specific question.
Oh, I didn't have any specific questions as I just kind of hopped on. I'm sorry about that. But we do have a prescriptions to go service where we have decentralized our outpatient staff onto the actual inpatient floors. So we basically help prepare prescriptions for patients prior to discharge. And in doing that, we have like a little bit of a lead time between when prescriptions are actually generated for the patient and when the patient actually gets discharged. So if we actually happen to see patients, issues with any prescriptions, we're able to kind of target and communicate with the doctor prior to the patient even getting discharged. So it's been kind of helpful.
That's fantastic.
I just have a couple of questions. I'm curious, do you have a protocol as to which patient population you target? Is it in general for all patients?
Yep, so it's all patients who go home. So we don't target patients specifically going to facilities, only because they usually take over the medication piece once they do reach the facility. So that's it. We're hospital-wide. And we do track patients. We're able to we do a little bit of chart review in the morning, so we'll check in on case management notes, progress notes, just to see where the patients are and when the anticipated discharge time is for the patient. When we obtain prescriptions, our pharmacists are checking those prescriptions up against the discharge summary or the discharge order, which is like the doctor's plan for what the patient should be on or should not be taken. Believe it or not, we've actually caught some things as a result of checking the discharge summary where doctors have said they intended to start patients on specific medications. Come to find out they never actually generated the prescriptions. So we've incorporated that into our process as well.
That's great. Are you tracking any of this? Are you doing any follow-up phone calls with the patients that you provide the service to?
Not at this point, unfortunately. It's a place where we would eventually like to get to, but currently, so we're, I think, at this point, 750 beds, I want to say, around health system. We have 2 pharmacists and a 4 technician team devoted to this, so that's a lot of beds and limited staff. So unfortunately, because of that reason, we haven't been able to follow up with those phone calls yet.
That's really great. We'd love to follow up with you and share some of the work that we're doing with some of the hospitals in our areas as well.
That was
That's
awesome.
awesome. Yeah, that's great. We'll definitely reach out to you.
Good. Good.
Thanks so much for jumping in and sharing. And I know Colleen Cardona is the Med Safety Lead. John Hobel is the Care Transitions Lead, and Steph Safer round out that team. So I know that they would love to connect and hear more about what you're doing and sort of figure out some feasible ways to track. One of the benefits of tracking is that you can show value, and value is one way you might be able to help get a little bit more staff to support the program.
Yeah, absolutely.
That's one of the hopes. Thanks again for jumping in. I'm wondering, I'm also seeing some feedback from Coastal in Rhode Island, and I'm wondering if one of the team members from the Coastal team could come in and share what they're doing. And it sounds unmute your line. Give it just a minute. And if you're shy and not able to do that, you can certainly type it in. And in the meantime, we've got somebody from St. Vincents who also has a med-to-bed program, and I'm wondering if you wouldn't mind sharing. If you're looking to increase utilization, so that to me sounds like you might be doing some tracking. And it would be pound 6 to jump in. While we wait for either St. Vincent's or Coastal to share what they're doing.
Hi. Hello. Hi, this is Sally from St. Vincent's. I don't know if you can hear me.
You can. Thanks, Sally. We'd love to hear more about your book.
Sure. Well, I'm a community pharmacy resident, and basically my year I've been trying to focus on med-to-bed, which is just like how BC kind of has it. We basically have an outpatient pharmacy on site, and what we request from doctors and nurses is to send the prescriptions to our pharmacy at least an hour prior to discharge in an ideal world. And what we will do is we will collect their insurance information, and we will be able to process their discharge prescriptions and deliver to the patient if they request it. And we try to always get a pharmacist to deliver the medication so that if the patient has any questions, they can ask the pharmacist directly, and we can also provide counseling, so that would assure medication adherence. So what we try to do is basically we're trying to increase our utilization because we have been finding that sometimes the staff members might not be aware that we have this program in place. So I've been working really hard to do in-services to nurses and providers, and also contact the patients themselves while they're in here and admitted. And we do have a tracking program. I have started a new standard that I'm hoping that we can extend to all patients, or at least all pharmacists, because currently I'm the only one who is doing it. So what I would do is once I deliver the medications and provide the education to patients, I would ask them if it's okay, if I can call them 2 to 3 days after discharge just to check up on them. And what I do is I have my own document that I would kind of be tracking the patients. So I will call them 2 to 3 days after discharge just to see if they're experiencing any side effects, they have any other questions, they got all their medications, because sometimes they might have to get other medications through a different pharmacy or something like that. And what I would do is I would check up on them. I would also make sure that they have an appointment with their provider, because once patients are discharged, the providers here usually only dispense up to a 14-day or 30-day supply with no refills, because we encourage follow-up for their PCPs. So once I get that appointment information, I ask them if I can call them again after their appointment, which is about 2 weeks later, and then I will call them for a second follow-up and make sure that they went to their doctor's appointment and see if anything changed.
That's fantastic, and I suspect that you have a lot of tracking in there, not only whether or not they're taking advantage of the program, but their outcomes as a result. And I know that our Connecticut team would love to connect with you if they're not already working with you to learn more about that and your results, so we could share that broadly. That would be fantastic.
Thanks for letting me share.
No, thanks for jumping in. And I know, Melissa,
had jumped in from Coastal. She was having a hard time being heard, but did want to share what they're doing in at Coastal. And bear with me for a second. So they are notified when the patient is discharged. They're doing a call to the patient within 48 hours. They're doing a complete med rec at that time and assisting to make sure that the follow-up appointments are completed. And if I recall correctly, there is a partnership with some local hospitals that if there are high-risk patients, and I suspect some of the ones on these high-risk classes, there's a handover connection with their office and the hospital. And Melissa, if I got that wrong, please jump in. I know that program has been in place for a while, so I'm not sure it's still in place. Elizabeth from Maine, I'm wondering if you wouldn't mind, I know you've typed a bit in about the work that you're doing in the ambulatory setting, but if you can unmute your line, we'd love to hear more. It's #6. Okay. I'm just coming back. So, well, Elizabeth tries to weigh in. We have had an opportunity to connect, and she is doing some amazing things in Maine. So she is a pharmacist who's embedded in primary care and spends a lot of time in the practice doing one-on-one and group teaching. Also, the shared visits with the pharmacist and the physician, and is really focused, like a lot of people, on reducing opiates. She's also looking at MPM, reducing polypharmacy where appropriate, fall prevention, and drug alternatives. And then you type in more, so I want to make sure that. And again, Elizabeth, if I'm missing something, we'd love to hear from you directly. You can always press #6. And that goes for the rest of you. We've been privileged, as Margie has said, to learn about the great work that's going on in New England on general medication management during care transitions, because it's such a huge opportunity, but also focus on these high-risk, the 3 high-risk med classes, and antibiotics. And so I would love to hear, and I know Margie would love to hear any of the work that you're doing in those 3 areas. #6 to weigh in on the phone line.
Hello? Hello?
Type it in. Hi, we can hear you.
Okay, this is Elizabeth speaking. Hello?
Excellent. Thanks for jumping in, Elizabeth. We'd love to hear more about the work that you've been doing and your results.
Yes, I'm working under a grant from the Community Pharmacy Foundation. Although I'm a hospital pharmacist by experience and have had limited experience in retail pharmacy, they were very generous and broad-minded and had me do a demonstration project to be involved in primary care practice primarily, and then while I was waiting for Board of Pharmacy approval for a collaborative care agreement, I did a fall prevention week with the community pharmacists and did some screening and found out some really useful information about problems that are happening in transitions of care. I chatted a line about formulary substitution that occurs in hospitals. And this is along several classes of drugs, ACE inhibitors, statins, proton pump inhibitors. And what happens on transition of care is that folks that are doing med reconciliation aren't fine-tuned to this. They end up sometimes duplicating their drugs, and that's a bad idea for statins and antihypertensives. And so there have been this is an issue that I'm trying to get publicized and get folks informed, and that's one of the main reasons why I'm on the line today, that we need to be very careful about that, both at the hospital and before discharge, or on the other end for giving the care plan to the family members to make sure that those details are taken care of. In the opioid area, right embedded in the practice, Dr. Reddy and I have worked together on his patients to get their opioid loads reduced. And we managed to do that overall 40% in 4 months without without adverse events. Nobody ended up in hospital or in the ED because of this, and our patient satisfaction scores were well maintained. These folks went through really a very difficult transition, but using multimodal approach by one-on-one visits for background assessment, joint sessions for adjusting their therapy, and group sessions. He made it mandatory for all 30 patients. We've covered issues such as gut health, diet, medication choice, nicotine, smoking, and the impact on pain management. So we've covered a lot of ground, and it's just a really big success story. I'm looking to replicate that in other practices.
Excellent. Thanks again for jumping in and sharing. And I know you have a very detailed way that you're monitoring and tracking the results. So I appreciate you sharing. I'm wondering if we might be able to hear from a few others on the call. Specifically, I've seen a lot about skilled nursing facilities. St. Elizabeth's Home, I'm wondering if you might be willing to jump in and share some of the work that you're doing. If St. isn't able to jump in, I'm wondering, Cheryl, if you might be willing to jump in and talk a little bit about what's going on in Westview. And it's just pound 6 to weigh in. I'm curious, too, to see if anybody's doing anything specific with regard to opiates. Obviously, this is a huge public health crisis. Does anybody have any specific interventions going on that they've implemented in their practice? Anybody implementing any of the CDC new guidelines? Just curious. I don't know. We got a quiet group today. Well, we know, Margie, that there's a lot of work that's going on around New England, and really some impressive things. And I think our goal in these sessions is to share those impressive things so that we can learn from each other, both in, where things didn't go so well and what worked, so that we can.
Hi, my name is Nina.
Hi, we can hear you.
So, just wanted to share how we do have a program, actually a department, Integrative Medicine department within our facility at St. Francis Hospital and Medical Center in Hartford that offers alternative pain therapies and modalities that has been proven to be very effective for patients in reducing length of stay and opioid use.
Excellent. Can you tell us a little bit more about that?
Patients who are interested in the service, they actually would request either before coming into the hospital if it's a scheduled surgical procedure perhaps, and they would need I believe it's a provider actually does need to submit a referral to the Integrative Medicine department, And there are different practitioners. In fact, my colleague and I just met a musical therapist in the elevator. This is an amazing instrument. Art therapy, energy healing, which is very similar to Reiki. There's chair yoga for ambulatory care, but on an inpatient, there's also breathing, assisted or guided breathing that can happen pre-op, just before people go into the OR, and guided imagery.
Excellent. And do you have a sense of what that's done in terms of, you said both length of stay, but also reduction of opiates? Do you have a sense of results yet?
Well, overall, I think quicker recovery, less anesthesia. I think the department within our facility is tracking it specifically for our facility, and I don't know what specifically those statistics have been, but it has been, they have seen improvements. And I know that's something, evidence-based research shows it does, decrease the length of stay, decrease use of anesthesia, the use of opioids, patients needing morphine medications, traditional pain meds, and also I think just overall wellness.
Excellent.
That sounds great. Yeah, thanks for sharing. That's something we'll definitely want to follow up with you on. Thank you for sharing.
Margie, before we go, I know we need to, I did want to mention, so it sounds like Coastal had some trouble being able to jump onto the phone line. We'll have to look into that. But Joanne did share that she's involved in their diabetes management program, where high-risk patients are followed by a diabetes nurse educator who monitors the blood sugars and treats hypoglycemia, and that all of those informational sessions are informational sessions, so educational sessions, and one that specifically covers diabetes medications. And again, I would just wonder if those educational sessions, if the effectiveness of those are being tracked. We'd love to hear more, and I know Cindy and Kathy and Rhode Island would. And with that, I'm wondering if I can turn it, Margie, back to you to wrap us up.
Sounds good. Thank you.
I'm sorry, can I ask one question?
Sure.
Sorry, this is Madeleine County. I'm a nurse practitioner in heart failure, and I cover kind of a broad area up the East Coast. And I just had a question about the person who was just speaking from St. Francis about the guided breathing, or in general. Does anybody or you have any interaction with your cardiology department or that team for advanced heart failure? Do you track or work with those patients, because med management obviously is a huge issue and there's lots of issues, but have you done anything with that? I know you were talking about opiates, but does anybody have any work or results or tools for the advanced heart failure population and reducing readmissions and length of stay? I actually do not work with the Integrative Medicine department. I work for an ACO, and there's, as far as I know, there's no direct or formalized program in place specifically with the cardiac program. So that's something actually I'll look into, because that's an area I'll be focused on. And I know that the director of the program, Integrative Medicine, she does work to raise awareness and collaborate with each department within the hospital to ensure maximum utilization of services. Right. Okay, but that's a good question, something I could look into and get back to you on. That would be great. Is there a way that, like, all of us, like participants, we have each other's email so we could reach out?
No, there isn't, but we can work to connect you offline. If you just reach out we'll provide our contact information on the last slide. So if you reach out to either myself or someone at the QIN-QIO in your state, we will certainly connect you with the person at St. Francis. So at this time, I want to start wrapping it up. This is a schedule of our Lunch and Learn series. Mark your calendars and please plan on joining us. Also, if you've had any success in the programs or projects that you've been involved with regarding med safety or antibiotic stewardship, we'd love to be able to highlight your work in one of these webinars. So please reach out and let us know. For those of you who are on the call today who are looking for ACPE accreditation, the code that you will need to put into the evaluation is safety. Morgan, do you want to tell everyone about the survey, please?
Sure. As you close out of the webinar today, the evaluation will automatically pop up on your screen. Please make sure to fill that out, especially if you need the ACPEs. We also, on our website, we currently have the PowerPoint for today's webinar posted there, so you can go check that out. And within the next few business days, we'll also add the recording and transcript for this webinar. So thanks again, and be on the lookout for invites for our next webinar on December 8th. And on the screen, you can see the list of your state contacts. So thank you, everyone, for joining. Have a great afternoon.
Thank you.
The leader has disconnected. The conference will be terminated in 5 minutes.